Hello, my name's Kath. I'm a paramedic and trainee advanced clinical practitioner in a couple of emergency departments in the north of England. Specialist interest in homeless and inclusion health, which I'll find a way to shoehorn into this somehow. So welcome to my monthly review of the Emergency Medicine Journal. I read it so you can pretend you have. So this is the December issue. I'm aware it's mid-January. What can I say? Quademic and Christmas, been giving out Tamiflu like that. And I currently have a cold. I'm hoping it's not going to turn into flu, but we'll see if we've picked that one up. So this week I've also been to the College of Paramedics Emergency and Crit Care Conference in Birmingham, which was cool, and I'll talk about a little bit at the end. So shout out to anyone else who was there. Okay, so I couldn't really identify any themes in last month's EMJ. So I'm just going to kind of go through it. From a paramedic perspective, pre-hospital perspective, and let's talk about where we get to. So we're going to start off with some pre-hospital research. So not super common. We're about to see why. So this was some Welsh research. So in the Welsh Ambulance Service and with the Welsh University, it was basically looking at, so a common theme we're seeing with these common presentations is research into stratifying these patients. So we've talked about it in the past. So if someone presents with chest pain, how do we pull off the people that are having a STEMI, send them up to cath labs, and then pull off the people at the bottom who are totally fine and send them home? And that gives us a little bit more time and space to get our teeth into the people in the middle. So lots and lots about stratifying these patients. So this is something similar. It's basically saying people who've rung the ambulance service with stroke-like symptoms, how do we pull off the ones? Actually, it's a transient ischemic attack, so it's resolved before the crews got there. Can we refer them to an outpatient follow-up rather than taking them to ED, saving everyone time and money? So it wasn't a trial, it was a randomised feasibility trial. So basically it was doing this, basically exploring whether this was worth doing a full trial on. So it was pre-hospital, it recruited a bunch of Welsh paramedics, and it was saying, if you see someone and you think it's TIA, here's a new pathway, refer them for outpatient follow-up to this like TIA clinic, and then looked at what happened. It used an ABCDE2 score for assessing these patients, looking at risk factors and presentations and things. And then, there was this referral pathway available to them. So, various issues. Basically, the conclusion is this isn't going to move on to an RCT or further testing. It's not cost effective, and there's a few reasons why. So it seems like they recruited a fair amount of paramedics. There was decent buy-in from frontline staff, but there was low patient identification and referral rates. Like, a handful of patients were actually referred appropriately to the outpatient follow-up. And they described this as a low-volume question within a high-volume ambulance service. So I guess, and this is kind of the curse of some pre-hospital, and maybe ED work as well, like the breadth of patients you see. You might be a paramedic super keen to take part in this research, but if you only see one query TIA in the 6-month period that they're doing it, then you don't have much opportunity to actually make those referrals. So not lots of referrals happening. Also, halfway through the study, NICE guidelines changed, and they said, actually, we advise against using ABCDE2 to assess these patients or to support decisions. So that kind of undermined everything and was a bit of a nightmare for them, I imagine. Also, there was loads of delays. So this study began in 2016. It's now 2025. So cheeky pandemic. So COVID hit halfway through, nightmare. And also they had some delays in gaining research permission, which I imagine were deeply political and they don't go into. But the whole thing kind of sounds like a nightmare, actually. So it's not progressing to RCT. It's interesting in terms of looking at what are the challenges of pre-hospital research. It might even be worth citing if anyone's writing about that. And also just shout out to that team, because it sounds like it was years and years of stress with a fairly frustrating outcome. So no progress there, although I think, again, useful for us in terms of thinking about how do we pick out these low-risk patients and high-risk patients, because they also talk a bit about how do we pull out the high-risk patients with stroke symptoms. And they've talked a bit about pathways similar. So we've got PPCI for patients having STEMIs. Do I need to explain all of these things? You're paramedics. So if someone's having an MI, they've got a blood clot around the heart, feeding the heart. You bypass A&E, you go up to PPCI and have immediate intervention there. And it was talking a bit like, actually, is there a version of that for thrombectomy for strokes? So I guess in tandem with like TIAs go to outpatients, and then actually the really poorly strokes bypass ED, bypass all that waiting time and go straight up for intervention there. So useful being aware of that like approach to patients, and maybe that's what the future is going to look like for all these different patient groups, of like that stratifying and then different pathways for them all trying to take pressure off ED. Something else worth being aware of as well is like this hasn't worked out. There isn't that pre-hospital TIA referral pathway, but we are seeing SDECs, lots of SDECs pop up, which are same-day emergency care. So they're somewhere that's not A&E, so patients are not necessarily an accident or emergency, but they do need looking at. And actually, there's loads and loads of pathways popping up for things like this, and I can imagine that like a TIA SDEC referral could be a really valuable pathway. So all is not lost. Next up is a study, original research, by 4 million doctors. So there's something called TURN, which I hadn't come across, which is the Trainee Emergency Research Network. Basically, it's loads and loads of doctors, trainees. I'm not going to call them juniors because they're really not, but trainee doctors, basically, all collaborating across dozens of hospitals. And this research was around the use of CAT scans when we're suspecting subarachnoid hemorrhage. So is there a bleed on the brain? Do a non-contrast CT, so you're not putting contrast into the patient's veins. Usually if you are suspicious of a subarach and the CT is clear, then you would then do a lumbar puncture. This research is like, actually, can we just make the decision using the CT only, like without following up with a lumbar puncture, because there's risks of a lumbar puncture, and you can get false positives. And yeah, they had a really big sample size. It was across loads of hospitals, and the conclusions they came to are that broadly CT is sufficient to exclude subarachnoid hemorrhage. So if your CT is clear, you could be fairly confident. You're never going to be totally confident really of anything ever, as long as it's done within 6 hours of onset. So we're thinking subarach, you're going to get that sudden onset, like thunderclap headache, worst pain you've ever had. So that's fairly simple, not super interesting pre-hospitally, but super interesting because it's got like the longest author list ever. Let me find it. All these guys. So that's straight on all their CVs. Good job, everyone. Next up is more about acute aortic syndrome. Basically, acute aortic syndrome, which is when you aorta coming up from your heart, looping around, going back down again, when you get when it goes wrong, when you get like a split in the wall of it, and it, without kind of totally exploding, it can create like this second lumen. Not good at all, and it can just explode and then you die because all the blood goes everywhere. So I was under-informed about this pre-hospitally in a way that makes me feel slightly terrified about what ones I might have missed. It's a big thing in EDs because it's really underdiagnosed in EDs. I think 25% are missed in ED, and that's partly because it can present with quite vague symptoms. You might get like a barn door one where someone's got sudden terrible tearing, central chest pain radiating to the back, but sometimes people present with really odd symptoms or super transient pain that is resolved before ED attendance. So lots get missed, and quite catastrophically as well. Like, it's a big deal to miss it and a really big deal to send someone home with it without investigating it fully. But the problem there is that the way we diagnose it confidently is with a CT aorta, which obviously we're kind of limited in terms of resources and money. We can't just CT everyone, and also radiation, I guess. So we can't CT aorta everyone that comes through ED's doors. So there's lots and lots of research into like, what can we do to get better at picking up these patients? How do we reduce the level of acute aortic syndrome misses? So this is all a computer model, this research. It's called Decision Analytical Modelling of Strategies for Investigating Suspected Acute Aortic Syndrome. So they had hypothetical patients. The patients were modelled, because sometimes they get real patients and then like model stuff, but this one is like all the patients are modelled as well, like nothing here is real. Okay, so hypothetical patients, and then hypothetically tested using a risk score alongside a D-dimer. I feel like there was something similar to this a few issues ago about chest pain, so it was using a risk stratification tool plus TROP, possibly. I'd have to go back and have a look. So again, we're seeing something that's being applied to another common presentation. So you've got a risk score which is based on things like pre-existing risk factors. So we know you've had surgery on your aorta recently, plus things like the way the pain is. So someone's telling you they've got tearing type pain radiating to the back. And then also examination findings, so like pulse deficit, or the classic one people talk about pre-hospitally, which is BP different in your arms. So someone gets a score from all those things put together to get like a risk score, and then this model is saying if we put that together with someone's D-dimer, so blood test that looks at the breakdown of clots, does that give us is that a good way of sieving out the patients that need to have CT aorta, rather than it just being clinician taking a history and being like, and what is the answer? Possibly. They basically said it's possible enough that we should move on to primary research now. So let's move away from hypothetical patients. Let's do some primary research. So where this will happen, I'm not entirely sure. It's a kind of cross-UK study. Sheffield, Bristol, Sheffield, Slough, Chesterfield. Aortic Dissection Charitable Trust in Chesterfield. Shout out to Chesterfield there. So I don't know where this research will happen or when, but this might finally be the magic bullet everyone's looking for in terms of getting better at spotting acute aortic syndrome in ED and sending less of them home with Gaviscon. I think there is AAS research in every issue of the EMJ, so we'll see what next month holds. Next one is pre-hospital, or involves pre-hospital. So this is from Japan, and it is called the duration of pre-hospital and in-hospital CPR and neurological outcome in paediatric out-of-hospital cardiac arrests. So was looking of kids that have out-of-hospital cardiac arrests. It was looking at the amount of time they were down for, like how long were they having CPR for, pre-hospital plus in-hospital, and then looking at their neurological outcomes of the children that survived. So the conclusion was longer CPR duration is associated with a lower likelihood of a 1-month moderate disability or better. By lower, they mean that if you have CPR, or if these kids had CPR for more than 64 minutes, so if you're down for more than an hour, you've got a less than 1% chance of surviving with a moderate disability or better. So when we say lower, we mean like, less than 1%. I think anyone that's had the misfortune to be involved in pre-hospital paediatric arrest, this isn't a surprise, is it? If you're down for an hour, the chance of you making it out are pretty small. I think the two discussion points are like, well, firstly, this is no shocking surprise to anyone, but what it's trying to do is build an evidence base for decisions making and discussion around termination of resuscitation. So basically it's giving some statistics for people having discussion with families, for clinicians having discussion with families, and also for teams. This kid's been down an hour. Let's be realistic about our chance of this kid surviving with anything other than catastrophic neurological injury, if at all. So that's what it's trying to do, is just inform really difficult decisions to make. And also it's interesting because it's moving just beyond that survival to discharge. Like, I think there's been this kind of talking about out-of-hospital cardiac arrests. It's all about like, what are our ROSC numbers? And they don't really matter if people aren't surviving to discharge. But also like, if you're surviving to discharge, like actually, what is your quality of life? So this is trying to be a little bit more detailed than that. And it's talking about like, what level of neurological disability is there for those kids. So that's that. I think there was 1,000 children involved in that study. So it was a retrospective analysis. So an audit, basically. The Sunday name. Next up, there's some homelessness research, my fave. So this was also a retrospective data analysis, the Sunday name for an audit that gets you published. So this is in America, where they have loads of homeless people, and it looked at nationwide data. So they have this huge data set available to them. There's this like rolling program that visits EDs. They send researchers for like a 4-week period, and they gather all this information. They put it all together, and what it means is there's this huge wealth of data for people to retrospectively data analyse. So it meant that they could look at 419 million ED visits. So that's quite a good sample size, isn't it? So they looked at adults aged 25 to 64. Did I tell you the name of this? The name of it is Suicide and Self-Injury Related Emergency Department Visits and Homelessness Among Adults 25 to 64 Years Old from 2016 to 2021 in the USA. So, adults 25 to 64, most of the homeless population fits into this age bracket. It also pulls out teenagers and really old people. Sorry, anyone that's 65, you're not really old, but you know what I mean. It's pulling out geriatric and teenage people because they would kind of complicate things. So 25 to 64, and they got data from 500 emergency departments. What were the findings? So 1 in 10 ED visits by people experiencing homelessness were related to self-injury. So this is compared to 1.7% amongst housed people. So up to 10 times higher, 5 times higher. Much more likely, people experiencing homelessness, much more likely to present to ED with self-injury related presentation. Also, of the patients presenting to ED with self-injury related issues, people experiencing homelessness were a greater proportion of those patients during the pandemic. So pre-pandemic, 8.4% of people presenting with some kind of self-injury, and during the pandemic that rose to 12%. So it kind of hit homeless patients harder, I guess there's a correlation between the pandemic and an increasing number of homeless people presenting with self-injury related things. I mean, America is different. Like, their healthcare system is super different. They've got different demographics. They've got different kind of social situation, but a lot of it is fairly transferable. The fact they're a high income country is, I guess, makes it pretty transferable. So the conclusion from the study: adults aged 25 to 64 experiencing homelessness was significantly associated with self-injury related ED visits. So what is there to discuss about this? I think, firstly, it's really important for everyone that looks after people experiencing homelessness in any capacity to understand this idea of the tri-morbidity of homeless health. So people who are homeless, have been homeless, have been through that, tend to have really poor health outcomes, really rubbish morbidity and mortality rates. And the way to look at this is through this idea of tri-morbidity. So people tend to experience poor physical health, poor mental health, and addiction. And when you put all these things together, they kind of exacerbate each other. They make it more difficult to engage in services and seek help and all sorts of other things. And the interplay between those three things, it's not absolutely everyone, but it's a common experience, is those three things, how they interplay can make for quite complex patients and quite poor outcomes. So that's worth bearing in mind. And then obviously one of the corners of that pyramid is poor mental health, and so that's going to leave people at greater risk of self-injury and suicide. So important to understand tri-morbidity of homeless health. Worth being aware of the data gap around homeless health. So it's actually very hard to pull out who your homeless patients are. Sure, some people might list NFA if that's an option, or you might know which homeless shelters there are to look up by addresses. But often people have an address that they'll give, even if they're not living there. There's a lot of stigma around homelessness, so people might not report it. If people are hidden homeless in the sofa surfing or living in vehicles, they might still have an address that they give. So it can actually be really hard to do this research because it's not always obvious and it's not always coded appropriately. When I worked at an inclusion health GP, specifically with rough sleepers, System 1 didn't give you an option to put in that ZZ99 postcode for rough sleepers, so you had to put in something. So we ended up giving everyone the address of the GP practice, which is great for our GPs that understands that that's what their address is. But actually, if you wanted to audit those patients externally, you would have no idea of that. So we would code them as well, but it meant you couldn't search by address, you couldn't search by the ZZ99 postcode. So systems tend not to be designed around those patients. Which is why there's so much exclusion, and it's why there's inclusion health work, because it's kind of understanding what those barriers are to care, and barriers are to even working out where the patients are that you need to be supporting. Other things: rise in homelessness during the pandemic in America, and also worth mentioning is at present there's really long waits to be seen by a clinician in EDs across the UK, and that's a massive barrier to care. I mean, for everyone, because it's hard to wait, but particularly for people experiencing homelessness and people in addiction, there's a big overlap between those two groups of people. I think if you the fear and the anticipation of withdrawing from opiates or alcohol is huge for people. It's so unpleasant that once you've been through it, you anticipate it. So I'm told, and that can make people really struggle to wait. And I think sometimes in ED, when people self-discharge, it's a bit like, oh, well, that kind of proves that they didn't need to be here, but that's not true at all in my experience. And actually people self-discharge out of frustration, and often there is an issue that has not been addressed or fixed, or even assessed, and either it gets better. I mean, I've seen rough sleepers not seek medical attention for broken bones that have they've kind of just let them to heal, often with, like resulting deficit. Or they deteriorate and present to ED like later and sicker, and that's a pattern that we see in homeless patients, so it's worth being aware of. And also be aware that homeless patients are likely to rely on ED for healthcare. They struggle to access primary care services, and that's why you have specialist homeless health GPs and like inclusion health GPs, partly because ED can't provide that primary care service, and also it's not a good use of ED resources. It's kind of frustrating for everyone. Then the last thing I'm going to properly get into is about olanzapine. So you might have come across olanzapine. So it's an antipsychotic drug. It's for the treatment of schizophrenia. You've often seen it taken orally. People take olanzapine tablets, but you can also have it as a depot injection. So it's like a slow release injection, intramuscular injection. Slow release, people get it like every 30 days. It tends to be people that struggle to take daily meds for various reasons, and people may have it under a community treatment order, so they don't have a choice. So once a month they go and get a depot injection of olanzapine. So this is a guide to olanzapine post-injection delirium sedation syndrome, PDSS, another acronym for you there. So it's about olanzapine PDSS after long-acting olanzapine depot injection presenting to the ED. Basically, guidelines, what does it look like, what do we do about it? And I think it's worth discussing because it's definitely something seen pre-hospitally, and I think it's a really useful differential if you find someone flat out or acting a bit strange in the city centre, and it can just augment your differentials a little bit more than an overdose of something. So PDSS is characterised by sedation and or delirium shortly after the injection of olanzapine depot. People often tend to call this depot shots. They might not specify olanzapine if you're speaking to the patient. And they think it is caused by inadvertent intravenous injection of olanzapine. So it's supposed to go IM and diffuse really slow or be absorbed really slowly over a month. If someone hits a blood vessel, they might inject all of it or some of it into the bloodstream, and so people end up with a really high concentration of it in their blood, and then everything goes a little bit wrong. And of course, with it being an injection, it's bypassing the first pass mechanism as well. So 90% of the time, so 9 times out of 10 occurs within 1 hour. So someone gets a depot shot, within an hour everything's gone a little bit wonky. So in terms of presentation, we're looking for sedation, agitation, delirium. And the important thing in this one is that patients can alternate between. So they might be super flat, then they might be super raggy, and then they might be super flat. Clearly quite challenging to manage, and fairly specific in terms of working out what's going on is that moving between these different states. Other presentations, you might see there's anticholinergic symptoms, so dry mouth, tachycardia. Anyone's done prescribing, you'll have been taught for all of this. Urinary retention. You might see extrapyramidal symptoms, so the pill rolling, dribbling, muscle stiffness and rigidity. On ECG, if you can get someone to sit still long enough to get an ECG, you might see QTC prolongation. Long QT, calculate that stuff. Hemodynamic changes, and also you might see a bit of pyrexia, but not a lot of pyrexia, which I'll talk about in a second. So that's the presentation. In terms of what they would do in ED and beyond, not much. Admit people for a couple of days just until they're out the other side, and then it's like supportive treatment, maybe a bit of sedation if people are really agitated. So I'm discussing this really just because I think it's this useful differential to have. It can present quite similarly to a benzodiazepine overdose, and it might be that someone who gets monthly depot shots of olanzapine is also someone that uses benzodiazepines from the street, for example. So you might have these patients where you're trying to sift out what exactly you think is going on. So what would you look at to try and differentiate it? Well, firstly, these alternating mental states. Benzo overdose, you'd expect maybe somebody generally quite flat, whereas with PDSS, you'd see them kind of fluctuating. Things like the anticholinergic symptoms are more specific to PDSS. Also, as far as I know, and I might well be wrong, olanzapine isn't something that, especially the depot injection, isn't something that's really used recreationally. but do correct me if anyone's come across that. So if someone's had a depot shot, you would expect that to be documented somewhere. So that's the time when it's worth trying to pull up System 1 and see whether there's any documentation of that administration. Not least because you expect it like on that day. So if you have that from this morning, now the patient's presenting like this, then you've got a pretty solid case for it being PDSS. Also be aware of neuromalignant syndrome, which is not something I'm super well informed about, but I'm trying to learn a bit about it at the moment. So this is a rare side effect of antipsychotics. Most of the literature is discussing oral olanzapine rather than a depot shot. But this also presents with some muscle rigidity and stiffness and reduced GCS, so potentially some overlap. The thing you would look for in that would be a really high temp. So you can be a little bit hot with PDSS. If you're super hot, be more worried about neuromalignant syndrome. So that's that. Couple of quick ones. The International Roundup. The Canadian Journal of Emergency Medicine tells us that having a med student torpedoes your numbers and slows everything down. Fine. Are portable fundus cameras effective in diabetic retinopathy diagnosis in AD? Yes. And then lastly, there was a little bit of research into capillary refill, like actually is it effective? So they were asking, is capillary refill measurement actually useful to detect hemorrhage at the bedside? I'm presuming they're talking about like internal hemorrhage, because you like to think that if someone's like spurting blood that there's no one doing a peripheral cap refill. But basically, they had a really nice study design. They had some gadget that measures cap refill, like with a machine and not just like someone counting to 5 in what they think is seconds. So they measured people's peripheral cap refill, and then all the participants went and gave blood, so had their own little hemorrhage, and then they came back and did a cap refill again, and they found that yes, cap refill went from 2.4 seconds before blood donation and then 3.1 seconds afterwards. So cap refill is useful. Who knew? Now, there's kind of an evidence base for something we love doing pre-hospitally. So that is this month's EMJ, last month's EMJ. The new one's going to arrive any second and the whole cycle will start again. So we will look forward to reading that. Last thing is I went to the College of Paramedics Emergency and Crit Care Conference in Birmingham this week. So it was the first one ever and it was really good. Really full room. It had a focus on kind of human factors. I think the title was Under Pressure, and it was all about decision making in pressured environments. Where do things go wrong? What's the point of, or how and why pressure affects performance, not what's the point of pressure. But lots of interesting stuff, partly about pressure actually being a positive impact on performance, until you get too much of it and then you kind of get frazzled and freeze and everything goes a little bit wrong. But loads to take away in terms of managing that and anticipating it, and like what you can do from a systems perspective to prevent the frazzle, but also what you can do from an individual perspective. I don't currently do any pre-hospital work, but like there's a definite risk of frazzle in ED, either from a kind of resus environment, which is, I think, has some similar pressures to pre-hospital, although it's a lot more controlled, but also just super busy departments. Like there's lots of interruptions. It's very hard to finish a sentence. I was so busy the other day that someone interrupted me and I started talking to them, and I went back and I'd been interrupted mid-signature. I was prescribing something and I'd like written half my name and then been interrupted, and it was like, man, this is like how you can't even finish a train of thought. You can't even finish writing your own name. So that's the kind of level of intensity in ED at the moment. So it felt like a really like good timing for this conference, and I definitely took a lot away. In terms of the concrete things I'm going to take forwards is skill drills. There was talk about these like halo skills, which are high acuity, low occurrence skills. So like when you're a student paramedic, you get taught to decompress the chest, needle chest decompression. And it's not very difficult, but you get taught it. And then I've done it once in 12 years. And that was 7-8 years since being taught it. And it's pretty scary, and it's not very complicated, but it's scary when you do it once a decade. So this was talking a lot about skill drills, and it was saying how teams like HEMS and HART and Crit Care, like they have all this time set aside to do all these drills, to do simulations and things, and actually like, especially if it's specific procedures, get that muscle memory and repeat it. So it's like, yeah, you might be doing it on a human for the first time in ages, but you've been doing it on dummies loads, and you've got that muscle memory and you know what kit you need. And I think DCAs are not getting that time on the road, and they're also more at risk because I think Crit Care actually probably decompress a lot of chests. Whereas if you are on the road, you can go a long time between those kind of jobs. So it made me want to make more time for drilling and to work out how to fit that into the ACP team, because there were all these procedural skills I'm trying to get better at. But then it's like you don't really want to be working at like how the packaging opens, like when you've got a patient in front of you. So I'm going to go do some drilling. It talked about mental preparation, which I think I've been doing intuitively, but they talked about various ways of approaching this. Now I'm working in resus rather than pre-hospitally, you get these pre-alerts, and I think I generally try and think through like what's the worst possible thing that could come through the door, what's the best possible thing that come through the door, what we're going to do in all these situations. And I take senior advice if I can, just in terms of like, oh, if this does happen, like where do we keep this stuff? So that's really useful in terms of making sure you're prepared. And you can also do it like hypothetically. You don't have to have a pre-alert or be on your way to a job. You can kind of just idly think about all these worst case scenarios and what you would do. Then there was stuff about breathing. I really like, there was someone who, you know, works at some really high level, like pre-hospital emergency consultant or whatever, and he was saying like when he opens the boot of his response car, he just takes that couple of minutes to take a couple of breaths. Doing lots of sims, it made me want to do some ambulance and ED like collaborative simulations. I don't know what the politics of that will be, but I would like to explore it. And it made me want to collaborate with pre-hospital stuff more, actually, because there's quite a division because of different trusts, and I've stepped from one to the other, but it made me think more about like, yeah, how do we like collaborate with paramedics and other ambulance stuff more effectively, because we are these like swarm teams with these teams working together, so how can we do some drills together? Also, Prince William turned up halfway through, so that was a surprise. My mum was very happy about it. He's a new patron of the College of Paramedics, so maybe one day we will be the Royal College of Paramedics. And then finally, I need to show you all the swag I got, because you don't get this at homeless health conferences. I have to report back. So I have children as well, so every time I went and just grabbed stuff, I was just like, to take this for my kids. So that was a great excuse. So I got a ruler from the RAF. I did not join the military, I just took the ruler. Some good pens. Really nice, real like nice tactile pen. I don't know what this is, but it looks really macho. Like they know their target audience. I don't know what that hangs on, but I love it. There's a tiny carabiner. I love it. There's a 10 centimeters of paracord and a little clippy thing. So once I work out how to attach this to myself and why, there's also Velcro for no reason. So that's great. There's a heart stress ball. Love that. There's a College of Paramedics lanyard, which I actually really appreciate. And it's not to wear at work and flex that I'm not a nurse, because people either presume in ED that I'm a nurse, fine, but I'm not, or a doctor, which I really don't like, because I'm very much not a doctor and don't want to be a doctor. So I think I might start wearing this in ED, not to distance myself from nurses, but to distance myself from doctors. Because even though I'm like very clear about my job role, I'll mention at every opportunity that I'm a paramedic. Patients still presume I'm a doctor, because I don't even know. Because I guess because I'm asking them about their health and talking about x-rays or something. I don't know, but that's my hope with this lanyard. And also, look at this free gift. A really sexy torch, but I have no use for because I'm not currently working pre-hospitally. But, you know, if there's ever a power cut, I'm sorted. And it's magnetic, so, I mean, amazing. Bring on next year. Yeah, I'm presuming it's going to be an annual conference from now, and it's going to be a solid one on my calendar, because it was great excuse to get out, a little bit of networking, and I learnt loads. So thanks to College of Paramedics for that. Thanks everyone for watching all 35 minutes of this, and see you next month for the January edition of the EMJ. See you later.